Hello, it's wonderful to be here with you all today. My name is Bethany Flanders. I am a PhD student from the U.S. studying healthcare ethics at Duquesne University. As a brief background, I hold a Master of Bioethics from the University of Pennsylvania, as well as a Bachelor of Arts in Medical and Health Humanities and a Bachelor of Arts in Philosophy, with minors in Biology and Ethics from Misericordia University. My research aims to bridge the gaps between philosophy and applied ethics in relation to moral dilemmas encountered in medicine and healthcare. The topic of my presentation today is Inequitable Allocation of Scarce Life-Saving Resources During a Global Pandemic, an Ethical Critique of Crisis Standards of Care Frameworks in the United States. As you may have noticed, I'm presenting a little differently than most. I am grateful to have the assistance of Satana Howery, who is my voice assistant for this presentation, as my physical neuromuscular disability causes speaking at an audible level very difficult. For the Q&A session following my talk, please feel free to email me with your questions or comments, and I would be happy to get back with you promptly. Today, I will be discussing how certain practices of resource rationing negatively impacts and infringes upon the rights and well-being of individuals with underlying disabilities and/or comorbidities. I will be unpacking several states' crisis standards of care guidelines and evaluating the ethical justifications for their rationing models, though it is important to note that many of the points I will be making can be appreciated in light of a broader context beyond U.S. health systems, as they are issues that all health systems grapple with during public health crises on a clinical, bioethical, and public policy level. The overall goal of my presentation is to establish a normative and clinical ethics-based critique of commonly adopted crisis standards of care frameworks, which concludes with an alternative equity-based approach to crisis standards of care. The COVID-19 pandemic, especially for countries such as the United States, who are less experienced with rationing healthcare resources, has forced healthcare systems to create and implement crisis standards of care guidelines in an effort to help clinicians make difficult ethical decisions in the face of limited time and scarce resources. There is no doubt that any crisis standards of care model is far from the ideal standard of care health professionals hope to provide for their patients and the kind of care patients hope to receive. Therefore, it is important to note that while a critique of states' crisis standards of care guidelines in the U.S. is provided, it is also vital to recognize the extreme complexity and even emotional burdens such difficult decisions bioethicists, policymakers, and health professionals must make when developing and implementing such guidelines. However, it is nonetheless vital to illuminate the ethical implications these guidelines have on the well-being and lives of individuals with disabilities, the largest minority group in America and globally, as well as individuals with comorbidities from a normative, clinical, and public health perspective. Let us begin by taking a look at Pennsylvania's Crisis Standards of Care Guidelines. Pennsylvania triage guidelines for adult and pediatric patients are comprised of two criteria that determine each patient's eligibility to receive critical care and critical care resources, though for the sake of time, I will be focusing on adult triage guidelines only. Triage clinicians must first determine if the patient needs invasive mechanical ventilation and/or if the patient is hypertensive with clinical signs of shock. If the patient presents with one or both qualifiers, they are deemed eligible to receive critical care. The second phase of triage guidelines is to determine the patient's priority level, and this is achieved by calculating the patient's evaluation score using the patient evaluation tool. Priority is given based upon a patient's likelihood to benefit from critical care and/or treatment and the predicted chance of long-term survival. The first version of the Pennsylvania CSC guidelines specifically included long-term survival in the sections of text describing the priority determination process, while the revised version eliminated this phrase from the descriptions. However, saving life years remained as the second goal of the CSC framework and is still included in the patient evaluation tool table of the SOFA scoring system, and is therefore conceptually and practically very similar to the first version in this way. In this CSC model, near-term survival is considered anywhere from 1 to 5 years, a length of time that would usually be considered as beyond the immediate scope of care under normal triage conditions, and thus deemed irrelevant to any ethical decisions regarding whether to provide critical care or treatments, unless otherwise directed by the patient or surrogate decision-maker. The patient evaluation tool provides a quantitative point allocation system to assist in the ethical decision-making required for the rationing of scarce resources such as ventilators, where the lowest scores receive the highest priority and the highest scores receive the lowest priority. Although the SOFA point system varies between adult and pediatric patients, the general structure of the model and its underlying ethical principles remain the same. There are two primary goals of this allocation framework: saving lives and saving life years. The former goal is determined by an estimated near-term survival prognosis, while the latter is based upon an estimated survival prognosis within the range of 1 to 5 years. Patients with a severe near-term prognosis due to an unrelated underlying condition are given less priority to receive life-saving and life-sustaining resources, even if they survived the acute phase of a COVID-19 infection. A severe life-limiting comorbidity is considered any prognosis between 1 to 5 years estimated survival. In the initial version of Pennsylvania CSC guidelines, a list of specific conditions that would receive high SOFA scores and thus fall under the criteria for receiving low to lowest priority was provided. Due to a complaint filed by Disability Rights Pennsylvania, DRP, this section was revised in the second version to no longer include this list. However, the exclusion criteria, still embedded in the ethical implications of the patient evaluation tool's quantitative scoring system, renders this revision meaningless and equally problematic. Consequently, as eligibility is defined in both versions of Pennsylvania CSC guidelines as being able to receive care only in the context of a system running under usual circumstances, the label of being eligible for critical care or treatment remains meaningless for a patient falling into this category in the face of a system running on scarce resources. Disability Rights Pennsylvania and other disability advocates who considered this to be a violation of Title II of the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, and Section 1557 of the Patient Protection and Affordable Care Act. This revision was made to avoid running the risk of providing overgeneralized guidance as opposed to allowing for individualized clinical evaluations based on the best available objective medical evidence. The establishing of a sense of epistemological and ethical neutrality through empirical medical assessments is a running theme through the guidelines text, with such objective medical knowledge providing meaningful access for all patients. This description of the nature of clinicians' acquired medical knowledge as objective misrepresents and ignores the true nature of such ethical analyses and the critical care decision-making process. This misrepresentation is known as the psychologist's fallacy. The psychologist's fallacy is an informal fallacy that arises when an observer takes the position that his or her perspective and subjective interpretation of an event is the factual and objective nature of that event. The notion that judgments made by clinicians on who receives critical care and who does not are based on objective medical knowledge is misleading, in that it excludes the recognition of the moral substance and ethical nature of such decision-making. This somewhat scientistic mislabeling of subjective ethical judgment and knowledge as objective, however, is not an uncommon error in medicine, especially in the clinical setting. Todd Chambers' 2001 Target article in the American Journal of Bioethics described a similar highly prevalent issue relating to medical narratives and the misidentification of bioethicists' case write-ups as objective texts, distinct from their subjective philosophical interpretations. Chambers describes how bioethicists often ignore the linguistic connection between cases and ideas or interpretations, namely in the way clinical ethics cases are framed. Case texts are usually spatially segregated from their philosophical ruminations and typed in different font styles, indicating that the presented case itself was somehow distinct from its subsequent ethical analysis and thus inherently objective. Doing so may create the appearance that one is basing their ethical assessment of a given case on concrete, neutral facts, thereby increasing others' confidence, albeit false confidence, and acceptance of the subsequent derived ethical interpretation of the case. Although Chambers describes this fiction of bioethics in relation to medical narratives, It is important to recognize that this fiction, this incorrect assumption of objectivity, is equally prevalent in emergency clinical assessments, where decisions regarding the allocation of critical care resources must be made. After all, clinical assessments, too, are a type of narrative. Thus, upon re-examining Pennsylvania CSC guidelines' assertion that clinicians are to use objective medical knowledge in order to provide meaningful access for all patients, it is clear that an assumption of moral objectivity is presumed, as the clinician's ethical judgment and clinical assessment are not only seen as one and the same, but also empirically and scientifically derived, and thus inherently objective. However, this sense of objectivity is merely illusory, as Chambers explains. But as narrative theorists know well, and most philosophers when pressed, there are no objective stories. All tales are told by some teller in a way that simultaneously reveals and conceals events. Pennsylvania was not the only state to adopt an allocation framework containing discriminatory ethical guidelines for CSC in 2020. Alabama, Washington, Kansas, New York, Utah, Tennessee, and Massachusetts also created similar guidelines for rationing algorithms. In response to the implementation of these CSC models, the Office for Civil Rights, OCR, filed complaints listing federal law violations, laws that were in place to protect persons with disabilities from discrimination, and the refusal of providing care or services based on disability. Utah's 2018 CSC framework, created before the pandemic, was perhaps even more explicitly problematic. Guidelines instructed hospitals to consider denying admission or transfer to critical care units individuals with severe and irreversible chronic neurological condition with persistent coma or vegetative state, known severe dementia, individuals with advanced untreatable neuromuscular disease, needing assistance with activities of daily living, ADLs, or regular use of mechanical ventilation, and children with progressive neuromuscular disorders with inability to sit unaided or ambulate, to name a few. In August of 2020, the Office for Civil Rights, OCR, reached a case resolution for Utah's CSC guidelines after the state revised the model to address complaints made regarding disability and age discrimination. Revisions included the addition of protections that prohibit clinicians from pressuring or steering patients into consenting to withdrawing or withholding life-sustaining treatment, the prohibition of blanket do not resuscitate orders, DNRs, removal of categorical exclusion criteria that disqualified persons with disabilities from receiving care based on their underlying condition, removal of the use of long-term life expectancy as a consideration in decisions regarding allocation and reallocation of scarce resources, the inclusion of a statement addressing that hospitals should not take and reallocate a patient's personal ventilator, and the addition of reasonable accommodations made to the state's assessment tool so that evaluations can be made on actual mortality risk rather than disability-related mortality risk. Tennessee's CSC guidelines, published in 2016, pose similar ethical violations, which the state worked with OCR to resolve. In June of 2020, OCR considered these issues remedied. Since the start of the pandemic, OCR has assisted in 38 states' revisions of their CSC guidelines based on more than 12 legal complaints made by disability advocates regarding disability and age discrimination. While OCR stated that Utah and Tennessee's revisions of state CSC guidelines successfully addressed all ethical concerns present in the previous versions, there is evidence that implicit discriminatory elements remain within the revised allocation protocols. Even with the removal of explicitly listed exclusion criteria, the SOFA and MSOFA scoring systems themselves are inherently discriminatory against patients with underlying conditions that affect the vital signs and laboratory values the scoring system utilizes. There are several reasons why it may not be clinically and ethically appropriate to use the SOFA or MSOFA scoring system for patients with underlying conditions that may affect baseline values such as creatinine, SpO2, or blood pressure, among other relevant variables. Firstly, since some abnormal baseline values have a benign cause or are considered normal for some individuals, having these abnormal values may not be indicative of mortality risk. Secondly, even if modifications were made to the MSOFA scoring system to allow comparison of patients' values with typical baseline values expected for individuals with the patient's underlying condition, it is impossible to separate actual mortality risk from disability-related mortality risk for some underlying conditions. Furthermore, it is unclear whether such a distinction even exists. Crisis standards of care guidelines that include qualifiers like those listed in Utah and Tennessee's allocation frameworks are not only based upon an individual's probability of near-term and long-term survival, they are also informed by the judgment that such lives indicate a quality of life unworthy of living, or at the very least, less worthy of living than other lives. A growing reservoir of qualitative studies has demonstrated the common bias clinicians have that persons with disabilities necessarily have a lower or poor quality of life. At the same time, many clinicians hold these beliefs while remaining ignorant of the true nature of the lives of persons with disabilities. Crisis standards of care allocation guidelines that incorporate judgments on quality of life are ethically problematic for three primary reasons: their failure to recognize the subjectivity of such judgments, their contribution to the perpetuation of medical paternalism, and the ethical assumption that all individuals view quality of life as relevant to determining value and/or purpose in continuing life. The first issue, the failure to recognize the subjectivity and thus potential inaccuracy of current and projected quality of life judgments, is a problem well illustrated in what has been called the disability paradox. The disability paradox illuminates a contradiction between public perceptions of the quality of life persons with disabilities experience and persons with disabilities' perception of their own quality of life. A significant stereotype exists among non-disabled individuals that persons with disabilities have a poor or undesirable quality of life, while the majority of persons with disabilities report having a positive quality of life. This bias is especially prevalent in medicine, with most clinicians assuming individuals with disabilities experience an unsatisfying quality of life, despite over 50% report experiencing a good or excellent quality of life. This discrepancy demonstrates the subjective nature of quality of life judgments and how vastly incorrect external assumptions by non-disabled clinicians or non-disabled persons can be. This assumption regarding the quality of life of disabled individuals also encourages a paternalistic approach to public health policy and clinical practice. During emergency medical scenarios, clinicians are forced to make swift ethical decisions based on their own judgment. Additionally, the practical advantages paternalism can offer in crisis care scenarios serve as another explanation for why such an approach is so prevalent. When faced with difficult decisions regarding resource rationing, medical paternalism may become even more attractive because less time is required for consultation with the patient and/or surrogate, and treatment decisions are instead mostly or solely decided based upon clinicians' judgments. Furthermore, crisis standards of care guidelines that base their criteria for allocation of scarce resources on quality of life judgments cause clinicians to assume that adopting such a paternalistic approach, whether clinicians consciously recognize the guidelines as paternalistic or not, is, ethically speaking, the right approach to adopt. But the inclusion of quality of life as criteria for resource allocation and rationing is not only ethically problematic because inaccurate biases can lead to inappropriate clinical decisions regarding starting, continuing, and stopping life-saving care and treatment during crisis situations, but also because of the philosophical nature of quality of life judgments. Perceptions and judgments on quality of life are inherently personal and non-medical, and thus irrelevant to clinicians' roles and duties. Consequently, such judgments become a violation of patients' personal freedoms, bodily autonomy, and right to self-determination. Lastly is the underlying unsubstantiated ethical assumption that all individuals view quality of life as relevant to determining one's value and/or purpose for continuing life. As stated above, over 50% of persons with disabilities reported a positive quality of life, It is also fair to recognize that there exists the other, less than 50% of individuals with disabilities who may consider their quality of life as less than ideal or poor. However, neither judgment on one's own quality of life is inherently, nor necessarily, the deciding factor, or a deciding factor at all, behind one's decision on whether life is worth living or continuing. It is entirely possible to experience poor quality of life while simultaneously willing and deciding to continue the worthiness and value in living life in the presence of hardship and suffering. This is because quality of life is not the only measure of value and purpose of life, nor is it always static and without the potential to change over time. The Pennsylvania CSC guidelines claim to be rooted in the ethical principles of fairness, consistency, proportionality, transparency, and solidarity, with the principle of consistency requiring equitable care and prohibiting discrimination based on patient age, race, gender, and disability, among other characteristics. Upon review of the CSC triage guidelines, there is little evidence of the consistent application of these principles. Instead, the CSC allocation framework is grounded in a utilitarian ethic rather than an appeal to medicine's near universally accepted bioethical principalism. The single highest aim of this allocation framework is made clear: saving the most lives and the most life years, or in essence, the maximization of the greatest good for the greatest number. What is the benefit of this ethic? Utilitarianism is simple, elegant, straightforward, and easy to implement. But there are significant problems with a utilitarian approach to public health. While utilitarian public policy necessitates a focus on the population as a whole, it often does so at the expense of the individual. Despite utilitarianism's attractive qualities, the dangers of the moral theory, especially when applied to the field of healthcare, is a widely recognized issue in academia. An uncontrolled pursuit of utility runs counter to conventional moral intuitions about justice and the care of vulnerable individuals. Because of utilitarianism's focus on consequences or ends, and never the means to such ends, the moral theory can be easily used to justify horrific violations against human rights and human dignity in the name of maximizing the good, or in this case, the well-being or health of the majority. One example of human rights violations committed in the name of maximizing the well-being of the population was the 20th century eugenics movement. Throughout history, disabled lives have been devalued and dehumanized by eugenic ideology, resulting in deaths and the attempted eradication of whole populations of disabled people. Eugenic thought was based on a primary objective to improve the human gene pool by promoting overall population wellness. Nazi medical policy was significantly influenced by utilitarian ethics. These atrocities, such as those committed during and around the time of the Holocaust, were a justified means to the end according to the application of utilitarianism's only central guiding principle: the maximization of the good for the greatest number. Utilitarianism, having only moral consideration for the majority of the population, leaves no room for moral consideration of minorities' well-being. This means that any action harming minorities is permissible and even morally good as long as it serves the well-being of the greater population. Savulescu et al. Argue in their 2020 paper, Utilitarianism and the Pandemic, that utilitarianism is currently viewed in a negative light, but that it was originally regarded to be a progressive, liberating theory where everyone's well-being counted equally. However, there is a blunt hermeneutical equivocation occurring in this statement. Savulescu et al., by appealing to the importance of the progressive notion of equality among persons, presumed a definition of human worth that is fundamentally inherent or intrinsic in nature. Yet utilitarianism's concept of human worth views an individual's value as anything but intrinsic. Rather, utilitarianism's definition of human worth is rooted solely in one's utility or usefulness to the external world and his or her ability to aid in the promotion of the greatest good for the greatest number. While intrinsic human worth provides a foundation for inalienable individual rights and equality, utilitarian human worth, worth derived from an individual's capacity to contribute to the social good, only provides a basis for a socially constructed, assigned, transient notion of individual rights and equality that can be revoked as easily as it was granted. Thus, the author's attempt to redeem a progressive and liberating sense of human worth and human rights grounded in utilitarianism is misguided and misrepresentative of the moral theory's true nature. Though this issue is not addressed directly, The author's suggestion to utilize utilitarianism as a starting point for ethical contemplation, rather than a comprehensively sufficient moral theory, may suggest their anticipation of this critique. But utilitarianism is not a moral theory that can be merged with any other notion of ethics that views human worth or individual rights as intrinsic, because doing so would be to undermine the very foundation of the theory itself. Consequently, a utilitarian-based allocation model can never be concerned with the individual for the individual's sake. Thus, if an individual is of concern under a utilitarian allocation model, it is only to the extent to which that individual helps to achieve the utilitarian aim of promoting the greatest well-being for the greatest number of people. American moral and political philosopher John Rawls illustrated utilitarianism's problem of dehumanization well, taking aim at the fact that the moral theory only promotes respect for the individual as a derivative of the theory, rather than recognizing respect for the person as a foundational principle. Such a theory could only serve as the moral basis for granting individuals human rights insofar as doing so benefits the greater good of a population. This form of human rights would thus be contingent and conditional, rather than inherent and inalienable. Rawls, however, disagreed with utilitarianism's concept of the good, its lack of distinction between persons, and the notion of respect for individuals solely as a means to an end. He explained that the utilitarian notion of justice indeed exists, but only as a socially constructed, useful illusion. Rawls's conception of respect for the individual, much like Kant explains in his Formula of Humanity, views the concept not merely as a means to an end, but rather as a central part of the good in itself, or an end in itself. This Kantian notion of treating individuals as ends in themselves subsequently demands further moral consideration in order to justify an action. This is where Aquinas' principle of double effect comes into play. According to this doctrine, negative effects may be justified if and only if the following conditions are met. 1. The action should be either ethically beneficial or ethically neutral. 2. The negative effect should not be the means by which the beneficial end goal is achieved. 3. The intention must be to actualize only the beneficial effect. 4. The beneficial outcome must outweigh the negative effect. When assessing the issue of reallocating ventilators, it becomes clear that only a few criteria of the principle of double effect are met. Although the intention to maximize the number of lives saved is a morally good motive, the negative effect, the death of an innocent person, cannot be considered morally beneficial or morally neutral. Furthermore, the patient's death was used as a means to an end in order to maximize the number of lives saved and better serve society as a whole. For these reasons, the reallocation of ventilators violates the principle of double effect. Populations most at risk for discrimination under a utilitarian CSC model are minorities, especially patients with underlying conditions and disabilities. Under normal triage conditions, those who are most critical and therefore least likely to survive without life-saving or life-sustaining care would be prioritized first. But under many state CSC guidelines, such individuals are prioritized last for both starting and continuing life-saving and life-sustaining care. What makes this alteration in standards of care justifiable? The obvious response, according to the CSC model's underlying utilitarian normative ethic, would be that such an approach yields the potential to save more lives. But the problem with this answer is that achieving this end does not come without significant ethical ramifications. In order to accomplish Pennsylvania and other states' CSC model's two-pronged utilitarian goal of saving the most lives and most life years, triage clinicians must violate the principles of justice and beneficence when treating patients with disabilities and/or comorbidities that affect the probability of benefiting from critical care. Even if such conditions only moderately affect the potential to benefit from critical care, these patients will automatically receive higher SOFA scores and therefore be denied equitable care by default, care they otherwise are eligible for according to standard triage models' delivery of treatment based on criticality of need. While there is an argument to be made for allocating life-saving resources to those who have the greatest chance of benefiting from them, it is also true that non-disabled patients and patients without comorbidities would almost always have a greater chance of surviving longer without immediate intervention than patients with moderate to severe disabilities or comorbidities who are at the same acute stage of the illness. This is an important clinical element that should not be dismissed from the guidelines' allocation decision-making procedure. Another important and relevant factor state CSC guidelines failed to consider was the disproportionality that already exists in COVID-19 infection rates among persons with disabilities and chronic conditions in comparison with the general population. Aside from being at higher risk for severe COVID-19 related complications, many persons with disabilities and underlying medical conditions require regular interactions with either home healthcare workers, personal care assistants, or in-facility caretakers and medical professionals, most of which work on rotating shifts with other patients or clients as well. Individuals who require these constant close interactions with healthcare workers, which account for more than 46% of persons with disabilities needing assistance, reported that their services could not be provided while simultaneously adhering to social distancing guidelines set by the CDC, which subsequently put them at increased risk for exposure and becoming infected by SARS-CoV-2 because of the inability to follow social distancing protocols, as persons with asymptomatic infection can also unknowingly spread the virus. In addition to these two factors that already cause this vulnerable population to be at a disproportionately higher risk of contracting COVID-19 and suffering from severe complications, many of these individuals have already made extra sacrifices and taken additional precautions in order to remain safe and slow the spread of the virus beyond the efforts, and for a longer period of time than the general population has taken. Yet, instead of aiming to address this disproportionality, state CSC models not only ignore the existence of the systemic disparity, but directly contribute to it by denying critical care and treatments for persons with disabilities and chronic conditions who would otherwise qualify for such care or treatment. I would like to close with an alternative theoretical and practical proposal that addresses these ethical concerns with current CSC models, a model that would complement standard equity-based triage guidelines while incorporating the prioritarian principle, careful application of the principle of double effect, and lastly, the implementation of the first-come, first-served principle as a tiebreaker when other relevant clinical and/or prognostic information is otherwise similar between two or more patients. These theoretical changes would help to assist hospitals in the ethical and practical challenges of the allocation and rationing of scarce resources during a public health emergency, such as the COVID-19 pandemic. This alternative approach to crisis care would avoid utilizing the dehumanizing moral framework and discriminatory strategies present in several states' current CSC models, which are based on factors such as subjective quality of life assessments and the problematic SOFA scoring systems. An alternative equity-based model, grounded on the prioritarian principle, would not disqualify patients based upon their underlying disabilities or comorbidities. Instead, priority would be given to the most critical patients who, without immediate intervention, would surely not survive. This model, based upon criticality of need, would therefore not give lower priority to patients with disabilities and/or comorbidities, except for in cases where a patient's death, disabled or non-disabled, is considered imminent and unavoidable even with life-saving intervention, or the patient or surrogate decision-maker has expressed a refusal of life-saving care. Additionally, the patient evaluation tool utilizing the SOFA point system should be removed from all state crisis of care guidelines. Such ethical concepts, particularly a patient's worthiness to be saved, cannot and should not be quantifiable. Despite states' revised text's assurance, such patient assessment tools do not indicate that some lives are not worth living. The reality is that quantifying such concepts, by definition, inherently devalues human worth. According to the National Center for Chronic Disease Prevention and Health Promotion, NCCD-PHP, health equity is defined as the attainment of the highest level of health for all people, a task which requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. While public health emergencies like the COVID-19 global pandemic make the task of ensuring equitable health care for all even more difficult, there is little doubt that significant normative and practical revisions must be made to states' current crisis standards of care models in the U.S. While this paper provides some groundwork for an alternative CSC framework, the central aim was to provide a philosophical and ethical critique which addresses remaining concerns present in current states' CSC guidelines. Further comprehensive development of the theoretical framework and practical elements of this proposed alternative model is required, but it is my hope that this presentation serves as a solid starting foundation for such an endeavor. Thank you all so much for listening.